We have a disclaimer, which is on the slides, saying all care is taken in us producing resources. And just acknowledging that Advanced Care Planning Australia is an initiative of Austin Health and is supported by funding from the Australian Government. So it is a national program that goes across all states and territories, even though we're actually physically based at the Austin Hospital. So what we want to do today is just try and recognise the patients for whom advanced care planning discussions are indicated, feel comfortable and confident to initiate the planning discussions with the patients and their families, and that's another important part. And then we're going to do some practicing of the skills required to hold the planning discussion, and then just know how we can support patients to complete advanced care plans. Advanced care planning is for anybody who may lose capacity to make decisions for themselves, and we define advanced care planning as a process of planning for future health and personal care whereby the person's values and preferences are made known at a future time when the person cannot make or communicate their decisions. So it is for the time when they lose capacity or they're unable to communicate their wants and needs. So it can happen any time throughout life, but we're probably focused more on the older Australians, but people with life-limiting illnesses, it's certainly appropriate for them. And in 2014, around 14% of Australians had an advanced care directive, yet 80% of patients will lose capacity to make decisions at their end of life. So we haven't got a whole lot of people that are getting this written down at the moment. So what we're going to do is, I'm really hoping this is going to work. So we're just going to watch a little video. It may just take a moment to...
Life is full of moments when it's important to be open, to be ready, and to be heard. This is especially true when it's time to consider advanced care planning. To help, here's how you can plan for tomorrow so you can live for today. Be open to thinking about your beliefs and preferences for care. This includes thinking about what you value most and the treatments you would choose to have or not have. Most importantly, you'll need to think of who you would trust to make these decisions for you. Be ready to talk about your beliefs and preferences for care with your loved ones, your healthcare professionals, and make sure they understand the way you see things. Ask questions if anything is uncertain, and try to consider what they might need to know about you to make decisions later. Be ready to make choices. Starting with the appointment of your substitute decision maker, they'll need to be over 18, as well as someone who listens carefully and understands your preferences. Either way, it needs to be someone you trust to make decisions on your behalf. Be heard by documenting and sharing your plan. First, write it down so that if others need to make decisions for you, they'll know what you would have wanted. Share your plan with your loved ones, your substitute decision maker, and the healthcare professionals responsible for your care. This way, everyone's on the same page. It may be difficult, but it makes sense to plan for tomorrow so you can live for today. Be open, be ready, be heard. To make your plan, visit our website or call for advice and support.
So now I'm just going to... so that's actually available through our Advanced Care Planning Australia website. We've got a number of these videos available, and they're there for both health professionals and consumers to be able to look at. So you can come and visit us on our booth and we can show you all of this sort of stuff. So we do have a booth here if you need further information or resources after this. So what we're actually looking at is to make sure that people get the care that matches their preference. We want to improve their ongoing end-of-life care, along with the family's satisfaction with that care, and also try and reduce some of the burden of people having to make decisions not knowing what the person's preferences are. So, and it also, if with advanced care plan for the older Australians, we often get less transfers to acute care if we've got a definite plan in place of how we're going to treat those people. So I don't know which button I'm pressing here at the moment. So we're looking at primary care, and why primary care? Well, it's because they have an ongoing trusted relationship with people and they're well positioned to initiate and promote advanced care planning. We want advanced care planning to happen in primary care rather than people being transferred to an acute care hospital in a crisis and nobody knows what's happening. Whereas if we're doing this in primary care, the conversation has been had. Even if we haven't got a plan, at least people have started talking about it. So just for those that do work in general practice, over a quarter of encounters with GPs are with people aged over 65 years, and half of these patients were over 75 years. And this is from the Australian Institute of Health and Welfare statistics from 2016. And GPs also spend more than half of their consultations providing for care for people with one or more chronic conditions. So if that's what the GPs are doing, we know that the nurses are doing that as well. So with primary care, you're more likely to have that sustained ongoing contact. I mean, I don't know the last time you were in a public hospital, but you see a different person every time you go in, where with your GP, at least you've got ongoing contact with people that you do know. And so we know that people are living longer with chronic, complex, life-limiting illnesses, and that modern technology is just going ahead in leaps and bounds. And so what we're looking at is we want people to look at what their values and goals are and then what they would like to do towards the end of their life. And we're going to do some exercises looking at that. But first of all, we're going to look at what would trigger the conversation, what would make you think about talking to someone about advanced care planning. And so it may be that the patients come to you, and I used to always think, nobody ever comes to anybody to ask about advanced care planning, but we've noticed lately that a lot of the seniors magazines and some of those things have been putting articles about advanced care planning in there, and we've certainly been getting a lot of inquiries on our advisory line saying, I've never heard of this, why don't I know about this, what can I do about it? So people are going to start coming in and asking about advanced care planning. If they've been discharged from hospital, and often somebody might have said to them as they're walking out the door, you need to think about an advanced care plan. Just when they've had a significant change in their life circumstances, often if they've lost a partner recently, that's a bit of a trigger, especially if they've watched them or had to make those decisions, they're in an intensive care tube and nobody knew what they wanted. That's often a trigger for the partner that's left to sort of say, I need to do something about this. If they're at the risk of losing capacity in the next 12 months, so early stage dementia, while they still have got some capacity, there's no reason that they can't be talking about their goals, preferences. The diagnosis of a new or chronic or terminal medical condition, obviously that's a time, sort of probably not going to be doing it on the day of diagnosis, but it's certainly, there's a trigger that maybe we need to bring these people back and have a little chat to them. And then when you're doing an assessment, and we're thinking the over 75 health assessment is the perfect time for people to be talking about that, and that's where the advanced project comes in. But also we're proposing an admission to a residential aged care facility, because we know that that's when they have KPIs and people are being asked if they've got an advanced care plan, and we don't want that just as a tick box exercise because they've walked into the aged care facility. Yes, we've had the plan. We want a meaningful conversation to have had. So that's segued in very nicely to have Josephine come up and talk to you about the screening tools and their project. And I'm just going to see if I can, no, I'm going to have to do...
Just escape.
Yes, escape this. And
third one down there, great.
Click on the...
Excellent, thank you.
Okay. Perfect.
Great. So I'm going to be talking about the Advanced Project, which involves training and resources for general practice nurses to enable you to initiate advanced care planning and palliative care with your patients. We've already introduced ourselves, so I'm Josephine Clayton, Shivali Natarajan and Kelly Arthurs. I'd also like to thank our advisory group on this project, in particular Karen Dettering from Advanced Care Planning Australia, and Liz Howcombe is another team member who's at this conference. She's Professor of primary healthcare nursing at the University of Wollongong. In this presentation, I'll give a brief overview of the ADVANCE project and then concentrate on one of the tools that have been developed for the project called the Advanced Care Planning Screening Interview Tool, and you can use this as part of a routine health assessment to introduce advanced care planning in general practice. So about the ADVANCE project. This project is led by Care in partnership with various health organisations and universities from across Australia, including Austin Health Advanced Care Planning Department. This project, like Advanced Care Planning Australia, is funded by the Australian Government in a national palliative care project. And it involves a multi-component training program to support nurses in general practice to work with GPs to initiate advanced care planning and palliative care in everyday general practice. We were first funded in February 2016, and our initial funding period went to the end of last year. And our target group in that program was specifically for you guys as general practice nurses. And we developed a suite of specifically designed resources, training videos, online learning modules, workshops, rural scholarships, and telementoring with our specialist palliative care nurse. And this was delivered nationally. One of the central resource that was developed for the project was a toolkit, which includes 6 screening and assessment tools which enable you to initiate assessment around advanced care planning and palliative care in general practice. This toolkit was informed by a literature review of the best available evidence, input from our national and international expert advisory group, as well as feedback from several general practice nurses, GPs and Carers Australia. The final toolkit was endorsed by APNA, as well as officially recognised as an accepted clinical resource by the Royal Australian College of GPs. The training is around implementing that toolkit into general practice. So the training enables general practice nurses to use a structured approach to promote awareness of advanced care planning amongst older people and those with chronic and complex disease, and to do this as part of routine health assessments so we can normalise the conversation. And secondly, to identify a cohort of patients within the general practice who might be at risk of deteriorating and dying, and in these patients to do a full assessment of their supportive care needs, including assessing the person's symptoms, most important questions, priorities and concerns, as well as their caregivers' needs and concerns, and finally to identify which of these patients might most benefit from referral to specialist palliative care services. As part of the toolkit, there's a guide which explains how to implement the screening and assessment tools in clinical general practice. The first phase of the guide is identifying patients, second is screening for their needs, and finally the third phase is evaluating the patient's needs. There's a copy of that guide in your handout, and I'll just briefly talk you through it. So the first phase, identifying patients, that involves identifying the cohort of patients for whom one or more of the advanced assessments might be relevant, and that would be any patient over the age of 75, and as well as any patient over the age of 18 who has one or more chronic and debilitating illnesses. There's a couple of tools then that can be used to triage what type of assessment that patient might benefit from. But regardless, this patient cohort, given that they're either elderly or have a chronic debilitating illness, it's very timely to begin to discuss advanced care planning with them, and to do that with a tool which I'll be talking you through shortly called the Advanced Care Planning Screening Interview Tool. By the way, one thing I didn't mention is that we suggest that you might be able to come across these patients and start to implement this program as part of a routine health assessment, such as a 75 and over health assessment, a chronic disease management plan, or you may also come across this cohort of patients for another reason, such as a wound check or a vaccination. Patients who meet certain criteria would then be appropriate for a full assessment of their supportive and palliative care needs. I won't be going to the details of those assessments within this particular presentation, but just for those patients, there's also a next phase, which is to evaluate the patient's needs, and there's another tool which can help you determine, once the patient's had their needs assessed, whether they might need additional support to meet those needs, including consideration of early referral to specialist palliative care services. So this is the Advanced Care Planning Screening Interview tool, and there's actually a copy of that in your notes, and I'll talk you through it. First, just to give you an overview of the tool. So the tool is basically a series of question prompts for you to use as a structured interview with a patient during a routine health assessment such as a 75 and over health check. It's not the whole advanced care planning discussion, it's just a way to get started, but a way to get started in a routine, systemised way so people don't fall through the cracks and not actually get educated about advanced care planning. So the aims of the tool are firstly to make sure that this cohort of patients are aware of what advanced care planning is, and at least have the opportunity to consider whether it's something they would like to explore further. Secondly, to find out who the person would like to make decisions for them on their behalf if they're ever in a situation when they couldn't speak for themselves. Thirdly, to ensure the practice is aware of any advanced care planning that's already been completed by the patient, because we found in our previous studies leading up to this project that it's quite often that the patients have gone off and seen their lawyer and completed advanced care directives but never actually spoken to their GP about it, and the practice is unaware. And finally, the last aim is to assess the person's readiness to further discuss advanced care planning and then to arrange the appropriate follow-up. The tool can also be used to record the patient's responses, so you could use a hard copy of the tool and write it in hand and then scan it and put it into the practice software. We've also got a fillable PDF version of this tool that can be incorporated directly into the practice software. So I'll just talk you through the tool itself. The first page is instructions for you, the nurse, as the interviewer. And there's a couple of phrases that you could use as a way of just opening the conversation. So for example, as part of the seniors' annual health checkup, we ask everyone about their future health wishes. Are you okay to talk with me about that for the next 5 to 10 minutes? And you can see that's a fairly non-threatening way to just start the conversation. There's a definition here of advanced care planning in case you need to refer to it later on in the interview. And there's also links to useful websites, including the Advanced Care Planning Australia website. This is the first page of the actual interview. And there's a series of questions. The questions that you as the nurse ask the patient are the unshaded sections of the document. And the shaded sections of the document are prompts for you as the nurse to consider. So as you can see, the first question's around who the person would want to make decisions for them. Next one around whether they've actually formally appointed that person. Then there's a few questions here to find out what discussions the person's already had about their future healthcare wishes, either with their family, another health professional, and whether they've in fact actually written anything down. Next one is whether they've actually heard of advanced care planning, and then a prompt to give them information about it if they'd like that. And finally, a question to assess their readiness to discuss advanced care planning, and prompts to sort of arrange who that they would like to discuss it with and who they'd like to bring along with them to the conversation. And then there's this open-ended question here. Is there anything else you'd like the practice to know about your wishes or priorities when it comes to your healthcare? When we were developing and evaluating this tool, it was amazing how often this simple question uncovered some really important issues that the patient had never talked to their family about or another health professional. So there's space to write those things down here in the tool. So we originally developed this tool in acute care setting, and then we adapted it for general practice and evaluated it there. And then for this national program, we adapted the tool further to ensure that it was relevant for every state and territory. So what I'm going to do now is I'm just going to give you a couple of minutes just to familiarise yourself with the actual tool. And then I'm going to show you a video of a nurse actually using this tool in a routine health assessment, so you can see how it could work in a kind of conversation. So I'll just give you a couple of minutes to just have a look. So I might just show you the video now, and as you watch the video, it's 8 minutes. So just to warn you that it is a longer video. But as you watch the video, I suggest following the tool itself, so you can see how the nurse uses the tool as a prompt to guide the conversation. So one thing that the nurses who've taken part in this program have found really reassuring is when you're first getting started with having these conversations, you don't have to remember everything. There's actually prompts to guide you each step of the way through the conversation. And so after the video, I'd love to hear your thoughts. So I'll just show you this now.
So Carolyn, if it's okay, I'd like to work through a few more questions with you.
Yes, okay, love. What are these ones about?
Well, as part of the seniors' annual checkup, we ask everyone about their future health wishes. Are you okay to talk with me about this for 5 to 10 minutes?
Yes, of course. Well, what is it you want to know?
Well, the first question is, have you ever thought about who you would like to make medical decisions for you in the event of an emergency, if you were too unwell to speak for yourself?
Oh, well, let me see. Since Frank died 5 years ago, I've more or less been attending to things myself. And Andrea, my daughter, she's intellectually disabled. Well, you know that. So I wouldn't want to burden her, Paul.
Of course, that makes sense. Is there anyone else, a close family or friend, whom you would trust to make decisions about your healthcare on your behalf?
Oh, let me see. I've got my niece, Sally. She's an absolute darling. I babysit her sometimes. And she and her husband, well, they often help me around the house with things, And she's a nurse, so she gets this stuff. I've got a brother, he lives interstate now, but he and I aren't that close. Do you know, I think Sally'd be the one. Yes, I think Sally. I'll talk to Sally.
Okay. The next question is, have you ever signed a legal document to appoint someone to make health decisions on your behalf if you were unable to?
Well, I've got a will, and I've made sure that all my finances, are there to look after Andrea. Is that what you mean, Paul?
Well, no, there's a separate form that allows you to appoint someone to make healthcare decisions on your behalf.
Oh, well, maybe I should get on to that too. I can talk to Sally about it, if she doesn't mind. Now, where do you get these forms from?
Well, there's a website we can look up that gives some information about things to consider when appointing someone to make healthcare decisions for you. It can also tell us where to get the forms that you need to fill out and how to get them witnessed so that they, if you wanted to say have Sally on the form, how to make it legal. I can print out some information for you if you like.
Oh yes, thanks.
All right. Now the next question says, have you talked to anyone in your family or a close friend about your wishes, values, beliefs about medical treatment and care in case you became seriously ill or unable to make decisions?
Well, I haven't spoken to my daughter. I mean, it seems weird now that everything's okay. She wouldn't understand all that, and it might end up by distressing her.
Yes, I can see how that could be hard for her. But you know, sometimes making these decisions when you're still okay enables you to make good decisions and to think clearly.
Yeah, well, that makes sense. I mean, Frank and I had this talk before he died. He went very peacefully, Paul. And that's what I want for me.
Well, have you ever talked to a doctor about your wishes, cares and beliefs about medical treatment and care in case you became seriously ill or unable to make decisions? Or have you ever written them down?
No, but maybe I should.
Well, that leads on to the next question. Have you ever heard of an advanced care planning or an advanced care directive?
No. What's that?
Advanced care planning is a process that helps you to plan for your future medical care. It involves thinking about your values, your beliefs, your wishes about the medical care that you'd like to have if you became critically ill or injured. It's a way to make sure people involved in your care understand your wishes in regards to medical treatment and care. And you can write these down in a document called an advanced care directive that records your specific wishes in the event of serious illness or you know, even if there's any treatment that you would specifically want or would not want.
Right. So that means that I wouldn't end up like Mary. Oh, sorry, Paul. Mary, she's a very dear friend. And she now lives in a nursing home with a feeding tube, and she had a stroke. She no longer is able to speak. And when her friends and family visit, well, she doesn't recognise them. Does that mean that this advanced planning, care, I wouldn't end up like Mary?
Well, it allows you to make your own choices about the care that you want to receive in the event that you are sick and aren't able to communicate clearly or make the decisions like Mary can.
Well, that sounds really good. No one's ever mentioned this to me before.
Well, it's like I said, it's not so easy to bring these up sometimes. So, would you like some more information about advanced care planning?
Yes, that would be good, Paul. I could take it home and maybe talk to Sally about it, and eventually, perhaps, include my daughter Andrea.
Maybe we can talk about this next time you come in. We could arrange another appointment.
Yes.
Maybe even bring Sally in.
Oh, yes.
And to discuss it with her as well.
That would be good. It would be good to have Sally here and to talk about these things. Yes. When should we do that?
Do you have a preference for who you would like to discuss this with here at the practice?
Oh, well, you are too, Paul, and Dr. Joel as well. But I think you first of all.
Of course. Is there anything else that you would like the practice to know about your wishes, your priorities when it comes to your healthcare?
Well, I don't want to suffer, Paul. Don't let me suffer. Or distress Andrea. I don't want to end up in a nursing home with a feeding tube and not recognise her. And I want Andrea to be taken care of. So, when can we make this appointment?
Well, that's up to you. We can organise it for next week if you like. Thank you for sharing it for us. It gives me something to think about that we can discuss next time when we meet.
Yes.
Do you feel comfortable with our conversation today?
With you, Paul? Very comfortable, yes. You know, it's a hard topic to bring up, I know that. But I'm so glad that we had this chat.
Good.
So I'd just be really interested in your on your thoughts, observations about the video, and whether that would be something you could see yourself, that a tool like this that you use in your health assessments.
I think it's a great tool. My concern is using it in daily work is the length of time. So I think if we're going, if I was going to use that, then I would have to make a point of trying to be faster with the things prior to bringing this up.
Yeah.
And then bring this up. My big concern is if there's no, then what?
As in if they don't want to discuss it any further?
No.
Or
They think it's something they would like to discuss, but there is no one to make these decisions for them. She was very lucky she pulled out her friend Sally. And what the devil is Sally going to do? When Sally when she takes this news to Sally and says, Sally, will you
be the decision maker, you mean? Yeah.
I imagine Sally's face is just going to hit the floor and think,
yeah.
This is a big decision.
Yeah.
Big role for me to take on as a stranger to your family, because there is distant relatives. They're geographically separated and maybe not very close emotionally either. But I'm wondering what the implications for Sally.
Yes, I think you've raised a really important point, and around what are the factors that go into making a good substitute decision maker, and how do we prepare substitute decision makers for their role? And I agree that's a big one. And there are some great resources on the Advanced Care Planning Australia website there about substitute decision making. Yes, but I think the role of this tool and this conversation is not necessarily to come up with all the final answers. It's just to get people to start thinking about these things, because as a specialist palliative care doctor, I certainly experience firsthand when, even if there's no final document or plan, if people have started to think about these things before they hit a crisis, if they've even just had a small conversation with their doctor, nurse, family, it makes the world of difference to then when the crisis point comes, that there's been at least some consideration of this. It's not such a shock.
I think it's great.
Yeah.
I think it really should be part of everything. Even for someone like me, I've recently had surgery, and it's right there on the form. Have you got? This is not just for elderly people.
Yeah.
Palliative people or someone with a chronic disease.
Yeah.
These things can just pop up, so that these conversations should be, around the dinner table.
Yeah.
I know in the aged care environment it's really very delicate because it's an emergency mission into us, and it often takes us 3 or 4 attempts to get that advanced care directive. It's not on your Christmas wish list to be there in the first place, and you're very distressed.
Yeah.
So it does take the conversation, then the relative or the decision maker. It takes us a lot to get signed off on that.
Yeah, and that's rightly so, that these are not just one-off conversations. They're ongoing conversations, need to be revisited over time as people's health and circumstances change. Getting started early makes it so much easier to have those subsequent discussions.
And the GP that they adore, that they've been with for 20 years, to be at that second and third conversation to actually sign off on it, because there's no trust, because we are the devil, really. We've landed here because you've fallen over at home, so we're not in the good books for a long time, and we don't take that personally, but that's how it is. But the good thing about that video is it gives you the tools to start, because sometimes it's really hard to start.
Yeah.
I mean, you know what you're trying to say, but
having the words and the phrases.
The words,
and not having to necessarily remember them because they're just there in front of you. You can see how it can be quite a natural conversation still, even though he was saying, "Oh, the next question is this." It didn't seem to matter in the genuineness of the conversation, that he was being guided by the prompts in the tool. The other thing I think, sorry, what was your name again? Deborah, that you mentioned about you need to hurry through, like for example, a 75 and over health assessment. To be able to fit that in, you'd need to hurry through the other parts of the assessment, and that's something that we heard from other practice nurses in our evaluation. And one thing that one strategy that some of the other nurses, because we had workshops all around the country, and some of the nurses would bring up challenges, and other nurses would have some really great suggestions. And so one of the suggestions was routinely booking in a longer, like the 60-minute advanced 75 over health assessment to be able, so that there is time to do it. But that does involve getting the practice manager on board and the GP, so that the longer consultation time can be booked for the health assessment. But there is a Medicare item for that longer health assessment. So it's just one tip that we learned from talking to nurses around the country that might be useful if you're looking at a way to actually be able to find the time for it.
One of the things we use with our over 75 health assessments is we did have our own years ago, and we thought, John Hunter Hospital had developed theirs. Yeah. So when we do our over 75 health assessments, because you push for time,
yeah.
We've got travel, we've got an hour, but we've got travel time in there. And then if there's memory problems, the doctor's saying, why didn't you do a mini mentor?
Yeah.
So you really push for time. So one of the ways around it we found was we hand out a blank form with John Hunter, which has all the questions, and we talk a little bit about what advanced health directive is. Yeah. So, could you have a little talk with whoever you want to be relatives about this, and then you come back into the doctor part of the health assessment, bring it with you. Yeah. And we scan it in, and we know who's got an advanced health directive. Yeah, that's a great strategy. Yeah, to kind of open the discussion, give them something to take away and think about it, talk to their family and get them back. Because we thought, we can have our own assessment and medical centre, that if they rock up to an emergency, they're not going to probably take notice of ours. So that's why we use the local hospital one. Yeah. And for New South Wales, there's now a standardised advanced care directive. It's not actually mandated that you use that one, but the New South Wales Ministry of Health has a standard one that's kind of like the default. And all for people in other states, there are all the state-by-state resources are on the Advanced Care Planning Australia website. So if you're looking at what form would be you could use in your own state, that's where it's a good repository there. Thank you. Any other questions or comments or observations? That's good timing anyway. So I just got one more slide just to finish up. We will be presenting later in the program tomorrow, actually, on the results of the evaluation of the national project that went between 2016 and 2017. Advanced Care Planning Australia again has been very generous in allowing us to share their booth. So our team will be there alongside Advanced Care Planning Australia if you've got any questions, if you'd like to meet us. And to let you know that we're very excited that we've got ongoing funding from the Department of Health until mid-2020. And our online training modules for general practice nurses are still available. They're APNA endorsed, and you can get 2 CPD points for completing those online modules. We also have mentoring available with our specialist palliative care nurse mentor, and to help troubleshoot any issues you might be having with implementing the program into your practice. And we have a big advisory group that we can call on to if we don't know the answers, that we can actually call on them to see if we can come up with some strategies for you. And that does give you another CPD point as well, if you'd like that. And we're in the process of developing complementary training for GPs, general practice registrars, and practice managers, and that will be available from October. In addition, we'll be developing a module for other nurses in allied health who work in primary care outside of private general practices, who liaise closely with GPs.
So to enable them to use these tools, or we're specifically adapting the tools to meet the different target groups' needs. And we'll be offering the face-to-face training again from next year in champion networks that we're giving, we're supporting with Train the Support, for them to also give provide support with the implementation locally. So these are our contact details, and our contact details are also on your handout. So thank you very much. It's been for your attention, and look forward to hopefully meeting you later in the conference. Now,
just escape, I think.
escape. Okay, there we go. Great. Yeah. Okay, so when we're Advanced Care Planning Australia has divided having the conversation into 5 different aspects. So first, we introduce the topic of advanced care planning and talk to our patients or clients about what advanced care planning is, and dispel any myths that there might be around advanced care planning. We then talk to them about a substitute decision maker who will speak for them. We talk to our clients and patients about their goals, values and beliefs, about their care and treatment preferences, and then we conclude the conversation and can assist the patient or client in the documentation of their advanced care plan or advanced care directive. So we have an example of the advanced care planning conversation that I'll play for you now. And what I'd like you to do is just to think about the different aspects of the conversation and just jot down what part of the conversation you hear as Mary is going through the conversation with her client. So I'll just pull it up now.
There we go, you can have your finger back now. Michael, it's really good that all your tests are stable, your CAT score's stable, or your blood tests are stable. It's really good to see that you're looking after yourself. Michael is visiting the practice today to review his chronic disease management plan. After my initial assessment, I checked with him to see if there were any other concerns. At these appointments, aside from checking out what's happening with your body, we also like to give you the opportunity to tell us what's concerning you, so we can help with that. Is there anything concerning you?
I must have been a little worried about what happens if something at home happens. What does she do? Ring an ambulance? I don't know if I really want that. I would like to stay away from hospitals as long as I can. But then, if I get seriously ill, is it going to be too much for her?
I can understand why you'd be concerned about that. Some things we can do, we can put you in touch with some community services, some palliative care, or some home nursing services that might be able to help you at home.
No, I don't think we need that yet. No.
I can understand that. But what about if you did fall? What would happen?
I don't know.
Something you could be thinking about now would be someone who could speak on your behalf if you couldn't speak for yourself.
Well, wouldn't they just ask me?
Yeah, they probably would. But you need to know what's important to Michael, what sorts of decisions you'd be making on his behalf.
We've talked about that.
That's really fantastic. So Sherry would know what you'd want if you did collapse and if you did need to go to hospital?
Well, we haven't really talked in that detail yet because, we don't know what's going to happen.
Yeah, it's hard to know what's happening in the future. None of us have got a crystal ball. Mine's broken. It is important to have a chat about that. No, it's important for us to know what you would want, so we could act on your behalf.
Right.
You've already obviously started the process, you're thinking about it.
And that's the first step. The next step is to talk with someone about it. You've started talking with Cherry. That's really great. The next part of the process would be to formally appoint that decision maker, someone who could speak on your behalf if you couldn't speak for yourself, someone who's confident, who knows what you would want. Yeah. The next part of the process is to write it down, writing down what your wishes would be if you couldn't speak for yourself, so we can all work off that same page. And then sharing it with the healthcare team, so with the hospitals, with anyone else who's caring for you. If it's not written in concrete, it can change as things change for you at home, as your health changes. So what we can do for you today is to give you some information to take away, maybe a form to fill in. You can think about it and have a chat with each other. I can record it in your notes so that you can bring it up with the doctor next time you're here. Would that be okay?
Yeah, no, that sounds good.
Yeah, that'd be great.
That sounds good.
Some weeks have now passed and Michael has returned to request a script. The nurse had mentioned to me about Michael's concerns and that she had brought up the topic of advanced care planning. It was important that I continue the conversation because these decisions need to be talked through over time. I see from the notes that Mary made that you were speaking to her about making an advanced care plan.
Yes. We decided Cherry would be my decision maker and say if I collapse at home, she'll call an ambulance. But she's not going to allow the doctors to put breathing tubes in.
Right. So did you appoint Cherry as your decision maker?
So actually I got the form here. Is that okay?
Yeah, this looks okay. Is it okay if we keep a copy here? So have you and Cherry had a chance to talk about what you would value most? So that it might help guide her to make her decisions?
Well, she knows that we don't want the breathing tubes in. What else should we be thinking about?
Well, it might be a good idea perhaps to get all three of us to make a time to get together to talk through some of this. I can discuss some potential outcomes with you and then you can let me know what you might decide.
At the next visit, we discussed Michael's values and preferences for care and completed all relevant documents. The instructions included that he didn't want intubation, but did want IV antibiotics. A copy was included in our practice records.
It's now 6 months later. Due to a chest infection, Michael's health has deteriorated further. Recently, an ambulance was called to Michael's home. He was having trouble breathing, and Cherry and Michael decided to make the call to take him to hospital. He's now recovering. Things are looking okay. But what's really worrying Michael is if Cherry can continue to manage his care. How's Cherry going?
She's okay. I mean, she's well, but being my carer and being responsible for the decision making, it's all getting a bit too much for her, I think.
Oh, okay. Have you spoken to her about it?
No, but I'm much sicker than I was when I first asked her to be my decision maker. And I don't want to be a burden to her.
Right. Is there anyone else in your family or anyone else that you would trust that could be an alternate decision maker?
Well, there's my daughter Jodie.
Yeah.
She's already doing a lot for us. But she may be willing to take on the decision making.
It sounds like it would be really beneficial for you if we sat down and had a look at all of your advanced care planning documents with you, Cherry, Jodie and your doctor and just went through it all and ensured that it was all up to date and that everyone knew their roles and responsibilities and felt comfortable about what you wanted. Is that something that you'd be happy for me to organise? Yeah. Excellent. Yeah, terrific.
When it comes to having a conversation about advanced care planning, it's everyone's responsibility. It's important that you identify when advanced care planning is being considered. You then need to provide them with the information they need and support them to make their own decisions. Finally, support the team around you by communicating what a client might be thinking and noting when changes to someone's plan might be necessary.
Okay, so apologies for the substandard acting of the hospital physiotherapist. So as you can see, that's an example of how we can bring up advanced care planning throughout the patient's journey, both from the private practice into the hospitals. What I might get you to do to begin with is just in your tables discuss with each other how the topic was introduced, who the substitute decision maker was, any prompts used to elicit goals, values and beliefs, the discussion on care and treatment preferences, and then how the conversation was concluded. So we'll just take a couple of minutes now, just on your tables, to have a chat to each other. Okay, so we might move on now. Just wanted to briefly touch on some different ways that we can bring up advanced care planning. Obviously, as we saw with the advanced project, we can use a hypothetical situation about if you were unable to speak for yourself, what treatment preferences would you want? And we can use that to help guide the conversation. The other thing, obviously, is if somebody does get distressed, sometimes these conversations can be quite confronting for people. It's really important to acknowledge that somebody's distressed and just to talk about it with them, and can sort of, I guess, stop the conversation and acknowledge that they're distressed, and then just offer to talk about the advanced care planning at a future appointment at a different stage. And the third opportunity as well is if somebody has a life-limiting illness. It's obviously a really important conversation to be having with our clients and patients. So we have some examples of conversation starters. So as we've heard, we can normalise the conversation by saying, I try to talk to all of my patients about what they would want if they became more unwell, and have you ever thought about this? We can also say, I'm pleased to see you're recovering from your recent illness. If you became very sick again, have you thought about what treatment you would or wouldn't want? And the other thing is that we can say, have you ever thought about your wishes regarding your future medical care? So there are lots of different examples. Has anyone got a few key phrases that they use within your practice? Do you have a way of introducing advanced care planning? Because often that can be the hardest part of the conversation, is just starting it. So, no?
Just talk about their wishes, really.
Yeah.
Your wishes and knowing the person to use their lingo without being condescending.
Yeah,
so,
absolutely.
On different cultures.
Yeah.
Aboriginal, it's not in their culture as it is in the Jewish culture, it's very, or if someone's a bit of a country person, and they're into their animals, or, an animal recently, because it's about that relationship.
Absolutely.
You can't have the conversation without I don't think, without a relationship.
Yeah.
And maybe because we've had the honour of having relationships in aged care and community practice.
Yeah.
I don't know if that came out of your research, but it's a long-term investment.
Absolutely.
On everyone's behalf.
Yeah.
Some people who've got animals have just died, I'll say, try and bring them in that way because they're distressed about their animals.
Yeah.
It's a cultural thing. You acknowledge their culture, that you're not doing very well at the moment, and you hate to make the wrong decision
on your behalf.
Yeah. Maker or whatever expression you use. I don't know. It just comes with practice.
Yeah. And the more you practice, the easier it becomes as well.
Well,
yeah.
It's great to have this framework, but there's a lot of variables, and
Yeah.
it's hard.
Yeah.
As I was saying, this is very Anglo, isn't it? I work in the rich cultural diversity of Western Sydney.
Yeah.
There's a million different
Yeah.
cultures, and I don't know that any of this would be appropriate.
What I should say is that we've actually got 15 different languages of interpreted information sheets on the Advanced Care Planning Australia website. So if we have a chance at the end of our session today, I'll go through those with you because they're a fantastic resource, and they've in Western Sydney. Yeah, it's challenging.
And if they're sensitive, you need to stop the conversation.
Yeah, absolutely.
Stand up, doors are slammed, you know.
Yeah.
It's really, but I think then once you've started the conversation, if the only thing you achieve is planting the seed and possibly giving a brochure.
Yeah, absolutely.
I don't want to be a bench.
Yeah. And then one year they might come back. Yeah.
It's on the coffee table.
Yeah.
And one by one your children might see it and, you know, they come back with coffee ring, you know, cups of
on the Advanced Care Directive.
You don't have to talk about it now, but the kids will pick it up, the kids will read it. Someone needs to know. That's how I've done it. I've only ever got to the point where I've given out a brochure.
Yeah.
And I've made it clear to the people, because people will say, oh no, I've got the will, or do I leave this with a lawyer then? And I always say, you're going to need to give us a copy as well.
Yeah.
Because if there was an accident while you're on a holiday, they're not going to ring you a lawyer.
No.
They're going to ring you a GP.
Yeah.
And a copy on the fridge.
Yeah.
On the
That
side
would be the other option.
The plastic sleeve with all the others.
With all the others.
Yeah. And then a copy with the substitute decision maker as well. Yeah.
And they often haven't heard of the Advanced Care Directive, so that's why I say your wishes, you know, and try and use the language, you know, and then eventually say, well, officially it's called this, but it's your wishes. Oh, well, I don't want to be, you wouldn't let a dog suffer, I'm not going to suffer.
Yeah.
Yeah.
It's a little big one like you get on.
Yeah. Or else.
But I like it that I've learned more. I may not be able to give any more to the patient other than the brochure to encourage them to go home and think about it and talk about it.
Yeah.
But then they might come back and say,
that's it.
well, I thought about that.
In 6 months' time.
We're going to put some things into place. What am I supposed to do next?
Yes.
And that's
yes.
the next step.
Yes, absolutely. So what we might do is just break for afternoon tea now, and we'll come back at 2:45. So you'll have half an hour to have something to eat and drink.
We'll make a start just so, because you've come back on time. I'm just going to play a video and we can have a chat about it. If it's going to work.
Are hard conversations. I've blown many times myself. I've not known what to do. And with this study coming out from Mass General where the patients had seen a palliative care physician, I realized that the gain they got was that really they'd seen 6 people who knew how to, that's the staff at Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Blanc. And Susan encapsulated what I thought the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number 1, do they know their prognosis? Number 2, what are their fears about what is to come? Number 3, what are their goals? What would they like to do as time runs short? And 4th, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator? As we come to the end. Do you want your heart shot? Do you not want your heart shot? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice, do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
Okay, so for those that don't know, that's Atal Gawande, who's a surgeon, and he realised that when his father became seriously ill, that he actually really was bad at having.
Oh, sorry. A physician in to do a surgical procedure without.
He realised that he did these conversations really quite badly, which is why he went off to explore it a little bit further. And I thought it was really good. So he's written a book called Being Mortal, and he explores aged care and the end of life. So it's really, he's quite a prolific writer, and I've seen him on lots of things. So I just think it's a really interesting thing that he's there, and as a surgeon and a doctor, he's saying it's not about whether you want to have CPR or not. We're actually looking at what you want out of life, and then those decisions can be made as a result of you writing down your values and preferences. Okay, yeah.
Is the book a young lady?
No, that was it. That other book was Charlie Cork's book. So Charlie Cork is actually an intensive care physician down at Barwon Health, and I can't remember the name of his book. Sorry. Letting Go.
How to plan for a good death. Thank you very much.
So what we're going to do now is we're going to do just on your tables a little bit of role play. We're going to get you to take the role of, one person takes the role of being the patient and one person takes the role of being the nurse. And we're going to look at Alex. So he's a 77-year-old male. He lives alone and he has a supportive daughter. He's got COPD and he's had a recent decline in function and independence. So this has got nothing to do with the pieces of paper on your desk, on your table, that comes later. So what I want you to do is just practice between yourselves, one of you, as I said, being the practice nurse and one of them being Alex, just introducing that conversation. Just take a few minutes, see how you go. How would you bring this up with Alex? And then I would like, after a few minutes for you to swap over and then take the alternate role. Does that make sense? Do you understand what I'm talking about? So if you just, amongst yourselves, just to have that, let's just have a go at starting that conversation, how you would do it with Alex, who's got COPD and he's just declining a bit, but yes. Okay, sorry to cut you short, but we need to we do have a few other exercises to do. So does anybody want to share how they found that? Was it difficult, easy, not as bad as you thought? Okay. So was that, how did you find that? Was that okay? I think most of you have initiated these conversations before, but yep, that was okay, practicing? Okay. All right, so when we're talking about the discussion, some of the things that you need to think about are the aspects of the future care. So talking about life-sustaining treatment, finding out their feelings about having CPR. I always say I think American television has a lot to answer for, where everybody has CPR, somebody gives them a shock, they sit up and they're having a cup of tea 5 minutes later, when we all know that's not the reality. But it's also things about, are they willing to have antibiotics? If we're getting into that aspect of it, some people will say yes, they would have a trial of oral antibiotics, but they don't want to have IV antibiotics. dialysis. There's a whole lot of aspects of that life-prolonging treatment that we need to think about. Also, just the preference for decision-making. We do know that some people, and it may be a cultural thing or just the age of the person, that they actually aren't particularly involved in their own decision-making. They actually want their family to make the decisions for them. So you've got to explore, are they making their decisions or are the family making the decisions for them? And just what their life goals and values are. Some people may say to you, my goal is to see my next great-grandchild be born, and I will do anything to make sure that that is going to happen, whereas for other people that may not be important. So it's what their goals and preferences are. And also I think we need to talk to them about withdrawal of treatment. The fact is that they will not be offered treatment that is not beneficial. So some people will say, I just want everything all of the time, just do everything you can to keep me alive. Whereas they need to know that if the doctors don't feel that it's going to be of any benefit, they're not going to be offered that treatment. So you do need to have those discussions, especially with the substitute decision makers, because that's one of the things, and I'm sure you've heard it before, where they come in and say, just do everything you can. I don't care what it costs, what you have to do, just everything you can, keep her alive, keep him alive. So we need to talk about that. And then palliative care. People have this thing, all right, if you even mention the word palliative care, I'm going to die. That's it. So we need to have those discussions about palliative care. So what we're going to do is just a really quick activity. This is just put your hand up. And we're just going to look at 2 scenarios. And I just want you to let me know if you think it would be much worse than death, somewhat worse than death, neither better nor worse than death, etc., etc. So the first the first scenario we've got is you are unable to speak meaningfully. You can't converse with others, but you can walk on your own, you can feed yourself, you can take care of your activities of daily living. How do you feel? Just put your hands up. There's no right or wrong answers. Who feels that would be much worse than death? Somewhat worse than death? Neither better nor worse than death? That's probably me. Somewhat better than death? Much better than death. And so the big thing here is, I just want people to know that you may think you know your patients, but you actually don't, because you don't know what people are thinking. We've done this scenario in a number of workshops, and I did it in a workshop where we had a husband and wife sitting next to each other as doctors, and they're both looking at each other going, really? You chose that? And so you're sitting there going, hello, this shows you've never had that conversation, have you? The other activity we've got is just, you often can't remember things such as where you are, you cannot reason clearly, you're capable of speaking but not remembering conversations, you're capable of washing, feeding and dressing yourself, and you're in no pain. So anybody think that's much worse than death? Somewhat worse than death? Neither better nor worse than death? Somewhat better than death? Much better than death? So once again, we've had a range of options. So it's just to show that there really is. And things can change too, depending on your circumstances, and it's why the conversation needs to be an ongoing conversation.
We have the tool, date night, couples date night, advanced care directive date night, where you have those conversations. Some maybe will never have time. There's always something going on in the house.
Yes.
Is there?
Yeah.
And it should be like,
made in America.
No,
I was going to say something like this advanced.
No.
It's made in America, but it is that. It's exactly
like November for the month of couple.
And there are a number of things,
That's what you should do.
Yeah, and there's a few things like death over dinner, and where you can have these conversations, yes, and things like that. So it is an interesting concept. But you're right. It's just I went to a community presentation and where we had people coming in, and it was the first I'd heard about advanced care planning, and most of them had their wills and that, and I had someone going back and she said, I've got my 4 children coming for dinner on Sunday and nobody's going to have a bite to eat until we've actually started having this conversation. And I thought, isn't that great, Yeah. That's how she was going to do it. So yes. I'm now going to hand over to Eleanor. Oh, first of all, we're just going to show you this. So if you can't read it at the back, it just says, just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me, okay? So there's the wife unplugging the television. This is my favourite cartoon. I love it. Very relevant in my household. So yes. Okay. So I'll hand over to Eleanor to talk about the next activity.
Okay. So the next exercise we're going to talk about a bit more is the level of independence we have for each aspect of living. So in front of you, you'll see 4 different pages. So you've got a page on your table, and what I would like you to do is go through the levels of function for that aspect of living. So it might be thinking, it might be talking, it might be eating or walking. And I want you to divide up best case versus worst case, and then put where your values sit on that line. So for example, if you have talking, it might be able to converse normally, able to communicate so that people can understand you in 7 different languages, etc., down to unable to communicate at all. For walking, it might be able to run a marathon down to unable to transfer independently. And then eating, it might be able to eat a full meal down to relying on peg feeds, etc. So if you can just talk about the different aspects of the different levels of function in that area. And this is just to help you be able to have those conversations with your patients or your clients, to be able to tease out what is important to them, what state of each of those aspects of living are important to them, and help them to determine what is more important to them out of what living well means to them. So if you can just fill out on that line. And what we might do is I'll just get somebody to stand up from each group to talk about what's on their page, what their best case scenario down to their worst case scenario is, and where different people are from your table on that spectrum as well. And whether or not the topic that you had may not necessarily be the deciding factor for yourselves as well. It may not be the most important value for you. So you may not be able to say where the line in the sand is for you just from that one topic. So who would like to start? Yeah.
Alice was speaking, the best case scenario was normal language conversing normally. Worst case scenario, especially about legislators, is no understanding of speech and not remembering. So maybe have dementia, can't remember. And in between we've got maybe you would decide what your needs are. And we both decided we'd be quite happy to be in this place, not being able to understand conversation if we were happy with, say, dementia. But if we're not happy with dementia people, perhaps we need a few more lines over to the scenario.
Yeah. And also assistive technology. There are hearing aids now, because my father's Greek and got dementia, that people speak too many English and it actually converses in Greek with him.
Wow.
So I imagine there must be assistive technology with speaking, or there must be something. Yeah. There's so much technology out there. So we sort of haven't factored that in. I mean, we go on forever. Lots of things in, but so I'm not that terrible person. I want you to do everything cute. I'm going to live to 100. But my husband's the opposite.
Yeah.
It's making you comfortable.
Okay. Cool.
So we have eating. So the best case scenario is eating and enjoying food, enjoying delicious food with a variety of textures and doing that independently, from cooking to feeding yourself independently. And then worst case scenario, we had tube feeding or having somebody force feed you when you weren't necessarily wanting to eat, and aspirating when you're eating. And then in between, we had if you're on a restricted diet and you're on puree diet or thickened fluids, and also having to be fully assisted to eat. I don't really know where the line in the sand is.
Wow, that's really good.
Yeah.
Yeah.
I think we talked about how it depends a little bit on if it's a temporary thing or a permanent thing, and also what other level of function you've got going on, whether it be
Yeah.
if you had a good otherwise quality of life and function, you might be willing to have tube fed, good tube fed.
That's why they're very dependent on multiple factors.
Yeah, absolutely. What about the next table? Thanks a lot.
So you've got walking. So for us, the best case scenario would be to be able to run in a marathon, do bushwalking, countryside walking. The worst case scenario would be bedridden, unable to transfer at all. So where we draw the line is we just wanted to have that sort of level of independence. So that's where we have pretty much drawn the line as a minimum acceptable, reasonable outcome to achieve some quality of life. Otherwise, if you're just bedridden too much. But if you can still go out and about, even though a bit of wheelchair can still go around, that's acceptable for us. Anyways, but it can be different for others. So that's it.
Thank you.
Rather unfortunately, we got thinking.
That's very fortunate for us.
Without the ability to think, you can't talk or eat. So none of these can really be separated.
Yeah.
And the best case scenario is to have full cognition and decision making and be capable of looking after yourself completely, from showering, cooking, cleaning, everything. Worst case scenario is to be right down the other end, where you're 100% dependent on someone else for everything.
Because of your cognition.
Because everything is gone. What part is gone? You've forgotten to shower, or you just can't belong into a conversation anymore. And it got really hard to draw a line in the sand because the four of us, as you said, have really different values. For some, being able to follow the conversation and be part of it was really important. For others to sit there and not be able to contribute to the conversation was okay, but to not be able to shower yourself would be the biggest problem. To not be able to feed yourself, which is all of those as well.
Yeah, absolutely.
So,
terrific.
Yeah, I wish I had got a different table.
it's hard, and they're all so interrelated. They really are. So, thank you. So I'll move on now to the initial questions when advanced care planning. So the first thing that we often ask our patients is, have you thought about what might happen if you can't speak for yourself? So you can ask, have you got a plan? Have you written this down anywhere? And are there any treatments you would or wouldn't want? And that might be because they've seen somebody else have go through a disease pathway, and they may have been exposed to various different illnesses. And so it's really important to understand what their experiences are that impact on their advanced care planning, and ensuring that we're also dispelling any myths as well. So if they have an experience of somebody who has had a stroke, and that person may be completely disabled by the stroke, but they're the only person that they know in their world that's had a stroke, then they're going to have a very different perception of what having a stroke is compared to a person who has had a friend who had a stroke who recovered completely. So it's really important that we enlighten our clients about what the different, what can be involved in the different disease pathways. Also understanding what people know about their current health status and ensuring that the health professionals around them are providing them with information and also guiding them in terms of questions that they might want to ask their doctor if they don't have a good understanding of their disease pathway. Sometimes meaningful questions don't help. So it might be good if somebody else in the room asks a question. For instance, in the example we saw Cherry ask questions about, oh, but what would happen if I wasn't around to give the instructions? Or you might have an example of how would you feel if you lost your independence, dignity, or were suffering? And that can help people to think about, okay, there might be another scenario in where I'm not comfortable with all treatments, or I'm not wanting everything. So it's important to sort of, if you can, have these conversations with the substitute decision maker in the room as well, so that they can understand what the person's perspective is on their health, and also be able to ask probing questions too. When the person reveals no clear limits but still wants to engage, you can start from the other end and talk about what their values are and what's most important to them, what they want to be living for. So, for instance, that great-grandchild's birth, or the wedding of their grandchild in 3 months' time, or stuff like that, and talk about what's important to them, and you can progress the conversation from there. And if a person declines to talk about the issues at all, you can acknowledge the right to decline to talk about it. That's absolutely okay. But it's also important to identify that the default position is to provide all medical treatment until it becomes certain that it cannot work. So it's really important when we're doing advanced care planning that we create an advanced care plan or an advanced care directive that can be used by both the substitute decision maker, if they're making the decisions on the behalf of the person, and also the health professional, should the person not be able to communicate their healthcare wishes. So an effective advanced care directive needs to provide absolute confidence to the health professionals and family to know when it is appropriate to stand back and not to implement treatment that may otherwise save life. People often write what they want or don't want without thinking about how a doctor or a family member will interpret it. And advanced communication skills include the ability to assist patients to create plans that provide useful guidance to doctors and family so that good person-centred decisions can be made. So I've created a number of different statements that we have seen or we have heard before in our advanced care planning conversations, and we're just going to tease them out a bit. So one of them is, when I am close to death, I would not want any treatment that would simply prolong my dying. So this statement sets a minimal bar, but almost no limit, because also doctors aren't obliged to provide non-beneficial treatment. So it sets a minimal limit that doctors and family are likely to adopt anyway. without any guidance from the person. And it does nothing that would assist the difficult treatment choices earlier in the course of the deterioration. So an example is, say if a person had a significant stroke and they were bedbound, but they survived the significant stroke, would they actually, they're no longer close to death, and they may obtain a pneumonia in the future or another infection which could be life-limiting. Would they want antibiotics in that scenario? So this advanced care directive doesn't really state about those sort of circumstances. We haven't teased out what's important to the person when they're living and what situations wouldn't they want to be in if they were, what is worse than dying to them. I would not want to end up in a nursing home. So we often hear this statement, and another one is, I would not want to be a vegetable. And we tend to say, so what does a vegetable look like? Why don't you want to end up in a nursing home? What is it about it? A lot of people really flourish in nursing homes because they have their care needs met, they're getting adequate nutrition, they have social interactions, and it can be a really good place for some people. So what is it about being in a nursing home that they don't want? And what if they had a significant stroke and they needed the nursing home to have their needs met? I mean, euthanasia currently isn't allowed in Australia, and so there might be a circumstance where people will need to be in a nursing home, but they might not want life-prolonging treatment should they be in a nursing home. So I guess it's really important that we actually tease out what it is about being in a nursing home with that patient and ensure that we understand what they are concerned about and allay any fears about that as well. I would not want treatment if I am unable to communicate with my family. So this doesn't define what the person means by communication. And as we saw, there are lots of different ways of communicating. So it might be through a hand squeeze. It might, if somebody has locked-in syndrome, it might be just through blinking, and you might be completely cognitively intact, but only able to communicate through blinking. So what is it that they wouldn't be happy with, and sort of teasing that out a bit more as well. I would not want to be resuscitated. And that's a really interesting statement, because within surgery, the anaesthetist, part of their job is resuscitating people intraoperatively, and it might be providing them with fluids. It might be giving them various different drugs to ensure that their blood pressure remains stable. So somebody may have, I would not want to be resuscitated on their advanced care plan, and not realise that, well, maybe it's the outcome that you wouldn't want. And maybe instead of I would not want resuscitation, we should be saying I would not want to not be able to communicate with my family and friends. I would not want to have a significant infarct that's incorrect. So what is it about not being resuscitated that you wouldn't want? So it's really important when we're doing advanced care planning with patients that we actually really tease out what they mean by each statement. The no heroics or no unnecessary medical treatment, again, they're incredibly broad statements, and it's difficult to understand what people would want. As health professionals, how would you interpret no heroics or no unnecessary medical treatment? Would it mean you wouldn't provide CPR? Or say if someone lost consciousness for say if they had a hypoglycemic episode, would it mean that you wouldn't want to provide them with the appropriate intervention to help them get out of that hypoglycemic episode? So I guess there are a lot of different situations that we need to consider. I would not want treatment if I cannot feed myself and I can't go to the toilet on my own and I can't recognise my family. So this is very specific, which helps, but would we need all of these things to be present in order for this plan to be activated? So that's what we'd sort of need to pick apart. Would the ability to pick up the food and put it into the mouth mean that the limit had not been reached? So these are the questions that you can ask your patients when you're doing the advanced care planning with them. So in terms of additional resources, there are a number of different resources on the Advanced Care Planning Australia website, and you can see there are different forms available for each different website, for each different territory or state, and we can actually click into them. For example, on the Advanced Care Planning Australia website, if we want to see what are the forms in Queensland, we can just click on to Queensland. We can find out about advanced care planning and the law, and how other laws are recognised in Queensland as well. So that can really help. So will my advanced care directive apply in other states? You can see. And it's incredibly frustrating having a different law in every state and territory, but it's really important that we are aware how those different forms and different laws are, how we use the forms in different states and territories. So, and then you can see how you can actually download the Advanced Health Directive or the Enduring Power of Attorney forms from the Advanced Care Planning Australia website as well.
Advanced Health Directive, is that just a different word for it?
Yeah, so that's a Queensland version of an Advanced Care Directive.
And just how valid are they, if legally speaking, if you can answer before I have to get...
Yeah, so... Yep.
If I've written down, I don't want active CPR.
Yep.
And I'm in a hospital.
Yeah.
Are the staff expected to go, it doesn't work?
Yeah. So in Victoria, yeah, I know in Victoria, if you've created an instructional directive, then it's actually considered unprofessional conduct to go against what is stated in the instructional directive. So we had an example where there was a patient who was having a cardiac stress test and they had a cardiac arrest, and there was an instructional directive on file, and the clinicians provided CPR up until the point where they saw the instructional directive refusing CPR, and then they stopped. And that's completely appropriate. So if you aren't aware of a document, then you can't. You treat in an emergency situation, but if you are aware of an instructional directive in Victoria, then you must follow that instructional directive.
Eleanor, if you just click on healthcare professionals obligations.
Yeah.
So here we go.
So it's very hard in the nursing home when you know that they've got a health directive not to resuscitate, and you've got that child saying...
Insisting. Yeah.
And it's...
Queensland's very, very specific in their thing. So we have all of these for every state. So what the healthcare professionals obligations are. So each state is very different in them, but I know Queensland has the sort of most criteria. You can only refuse treatment or CPR if you're going to die within 12 months, or 2 doctors have said that you're going to. And so there's a lot of things, but all of this is up on our website that you can download them as fact sheets as well, just to have a look.
So, and the fact sheets can also be good for the clients as well. They can find them really helpful. So I'll just show you the Queensland one.
So you can almost integrate that into your policy, couldn't you?
Yeah. Yeah.
That might be the way. Have you?
We haven't, I wasn't in general practice, we haven't, as part of our all care plans, have a discussion about advanced care planning and opportunity around group sessions for up to 10 patients. So we'll have a group session about what advanced care planning is, how they can have a discussion with their significant person, who they might choose as a significant person, what criteria that significant person needs to be aware of. I offer them the opportunity to fill in forms, and GP will come and sign off on medical coverage if that's what the patient wants at that time.
I think they look great.
So, and you can print these off, and so there are fact sheets for each different jurisdiction, and then we also have individual fact sheets as well, which are really great. So there are fact sheets for substitute decision makers and fact sheets for individuals as well as health professionals as well. So they're all really great resources to be able to also have the conversation with people as well.
You can come to our booth not tonight because we don't have any furniture,
tomorrow.
but tomorrow. Yeah, we'll have some hard copies of some of these forms just so you can see them.
Yeah.
Yeah, the advanced care in the law is a big thing.
Yeah.
Yeah.
If you have different aged care facilities throughout Australia, it's a big nightmare.
Yeah, it is, absolutely.
It's illegal to have different laws in
For our staff.
Yeah.
It's a big problem.
But I mean, would someone going for, say cardiac catheter, would anyone look to see if they had an advanced care group?
They have to in Victoria now. So certainly at yeah, so it's on the pre-admission questionnaire. So it's really great. It's quite standard across most health organisations to include a question about whether or not somebody has an advanced care planning document in their pre-admission questionnaire. And then it's a responsibility of the clinician to know what it says. Because, we've even had patients who have had an active do not resuscitate and been on the list for a kidney transplant. And so it's incredible. Like it's quite incredible. And so there's been a huge, with the change, so it was just a recent change in the Victorian legislation on the 12th of March. And so with that change in legislation, there's been a huge amount of work done within health organisations to try and upskill people in advanced care planning and improve their knowledge about the relevance of the forms. So it's been really great to leverage off with the change in legislation.
So is that the only state that has done that?
No, so there are legislations regarding advanced care planning in all jurisdictions, and there are statutory documents. Is it in all jurisdictions, Michelle? Or
North Tasmania or New South Wales. So
okay.
Tasmania and New South Wales don't have statutory documents, but they do recognise the documents that are available under common law. So other states have got legislation documents, and some of them say South Australia, you have to do it on their form. So each state is totally different. It's just a nightmare, especially when you think about the population that you're probably doing these for.
And the grey nomads and yeah.
Western Australia to Queensland to whatever, and you've got to know. And then the smaller states like Tasmania, so the patients are coming across to Victoria or South Australia to have surgery done, and so which forms you fill out, the states or theirs or yes. Yes. There's a lot of projects going on looking for harmonisation across all the states and territories, but everybody thinks theirs is the best, so it's
That's what you know.
Yeah. So the key messages from us are that advanced care planning is really essential to person-centred care. So it's not just about death. It's about what's important to the person, what are their values, what are their preferences. It can be appropriate for people who may lose cognition at some, or lose their capacity at some stage. In a fluctuating context, it might be even patients who have mental health conditions where they lose capacity. Advanced care planning can be really important for them. It promotes care that is consistent with a person's goals, values, beliefs and preferences. It also is really great for preparing their substitute decision maker for making healthcare decisions. It promotes that discussion and the knowledge transfer between people, and it really airs when values are different between the person and their substitute decision maker, and it's important that people understand that difference and respect it. It improves the outcomes for people, their family and carers, health, aged and community care workers and the health system. It's part of the routine care and the person's healthcare journey, and should be an ongoing process, so that we may begin it even in a hospital scenario and provide some information there, and then it can be developed over time with other community healthcare professionals. It may be initiated or completed by the person themselves or by health, aged and community care workers, and it's most effective when it has a systems-based approach. So it's really, I'd advise you all to look at the systems you have in your organisations that support advanced care planning, and see if there are things that can be changed to try and include it in the care of all people where it is appropriate. So advanced care planning is a process of planning for future health and personal care, whereby the person's values and preferences are made known so that they can guide decision making at a time when the person cannot make or communicate their decisions. So that's the national consensus statement for advanced care planning. And in plain English, we like to say, who would you trust to make your healthcare decisions, and what would you want them to say? And so the Advanced Care Planning Australia website has all of those resources that we've discussed. We also have a 1300 number to support advanced care planning, and that's both for health professionals and consumers. So you could even provide patients with a handout from the Advanced Care Planning Australia website, and then they might want to call Advanced Care Planning Australia for a follow-up discussion. And that service is available from 9 a.m. to 5 p.m. Monday to Friday. As I mentioned, there's the Advanced Care Planning Australia website. There's the Pally Aged Nurse, which is an app that supports nurses who are caring for older palliative care patients. And there are also clinical software available on HealthShare.
So for those that have got HealthShare on their systems, we've got a fact sheet, and it's just a one-page fact sheet that can be printed up. We've made it with less information than is on our website, because we know that people, when they print things up, only print up one side. So there's one for individuals and there's one for substitute decision makers. So you're able to print those up within the practice quite easily if you've got the HealthShare.
And then health pathways as well.
So you need to talk to your PHN. So not all PHNs have health pathways. Some of them have map medicine, but it's basically if you talk to your local PHN, they have pathways which are localised to your area, so the support services and things. So it may have links to our Advanced Care Planning Australia site, but would have your local services that you can link into as well. So that's something to talk to your PHNs about.
There's the Advanced Care Planning Australia education modules as well, and they go through sort of in depth what advanced care planning is, and they really support having the conversation. And there's a primary healthcare module for advanced care planning as well. There are videos. More videos on the Advanced Care Planning Australia website. There are the YouTube clips, the animations as well. And then Think GP is also has advanced care planning as well.
So for your GPs, if you need them to get into it, we've got, but all health professionals that are health professionals can jump on there and do an online learning module, but the GPs can get RSCGP points for it. There's also just a really quick video where Karen Devering's talking about the advanced care planning, and there's a blog as well, apparently. Not that I really know much about blogs.
So this is the Think GP website.
Yeah. So, and you can just log on for free and do that. And so as nurses, you can just use it as your CPD, you just need to take note of it.
And as I said, for more information, you can jump onto the Advanced Care Planning Australia website or call us on 1300 208 582. And also that's the website for the ACP learning modules. So thank you all for your time today.
There are evaluations on the table too.
Yes, so it would be terrific if you could give us some feedback with the evaluation in the final 5 minutes that we have.